Good afternoon, everybody. My name's Mike Reiter, and I'm the director of APS Healthcare, the California External Quality Review Organization. And before I explain what that is, I'd like to say a little bit about myself. I've been working in mental health in California, it's hard for me to believe, for over 35 years. I spent my first 26 years working for San Francisco County, getting to know Steve, and I did start as a clinical pharmacist, and I then learned how to specialize in other duties as assigned. And some of those became things like quality improvement, utilization review, medication monitoring, patients. I was fortunate enough that I was the contract monitor for our patients' rights organization. And I was also actually, one of my first administrative assignments was staffing one of our mental health board's committees, the Patients' Rights Committee, and I was still working as a pharmacist in those days, and I actually worked with those folks to develop our first medication consent forms, and this is in the early 80s. And really, just to say that that's how I really learned how medication works, not just by going to class or to even or just observing when people take it. It's talking to people who have taken medication, finding out what's important to them to know, for them to know about medication, and it really actually was a life-changing event for me. So I really appreciate the opportunity to come and talk to you folks. I think I understand the important role you play in your counties, and what I'm hoping to do today is to explain what we've been doing and give you some context. And also to talk a little bit about the data that we've had available and is available to you. Let's see. First of all, there's names. For a long time, we were APS Healthcare. Then a company bought us out. So just to divulge, a company by the name of Universal American, which is back east mostly, but is also in Texas and other places, and they do work on Medicare Advantage plans, and they purchased APS Healthcare. APS does not stand for anything. It's just it's an acronym that used to mean something else, and it just means APS. So they had a contest to try to can you come up with something that is meaningful but still has APS, and they couldn't. They didn't. Yeah, really. Thank you. Since 2004, we've had the contract to be the External Quality Review Organization for the state of California for specialty mental health. And commonly, we are referred to as California External Quality Review Organization, and you see the abbreviation often as CAEQRO. And if you want to go to our webpage is CAEQRO.com, and that's where a lot of data that and all the reports that we've written appears. And I'll show you a screenshot of that later on in the presentation. I also want to give you some references in terms of names. When I make a reference to a mental health plan, I'm considering, first of all, under federal terms of the waiver that specialty mental health services are provided in California, each of the 56 county-based mental health plans are mental health plans. There's also another technical name for them, but it would make everybody crazy, so I'm not going to say that. But we consider, and when we talk about a mental health plan, I'm not just talking about the county-owned and operated. I'm talking about all the services that the county manages. So it would be community-based, and so we have here CBOs, community-based organizations. I would talk about provider panels if they, in other words, if they contract with individual providers who see people in their offices. That's included in what I'm talking about, and all otherwise contracted other contracted services. Why do we exist? Also, I'll talk about it later on. The freedom of choice waiver is something we're going to talk about because that's the reason that we do exist. But let me see. Okay. Just so here's who we are. And one of the reasons I'm putting the names up is that a number of these individuals are available to you to consult. We have a number of individuals. Sandra Sins is our Director of Operations, and a number of people who report to her are known as lead reviewers. And I'm going to talk in a minute a little bit about what we do on reviews. The lead reviewers are the people who organize our reviews. And something I particularly want to point out is most of our lead reviewers have clinical licenses, but they also have this one designation. You'll see the initials CPHQ. They are certified, they've taken an exam, certification exam, and they are certified professionals in healthcare quality. And one thing I can say is there aren't any QI coordinators in the state who have this certification. We actually presented an overview of what it takes to be certified at the recent state QI coordinators conference. And then we also have a number of individuals who on this part of the organizational chart, who are technology reviewers. And the significance of that is we have a responsibility to review the technology that creates claims for integrity, because we're there because it's a federal requirement. And so these are individuals who know how to use, many of them have worked in counties and have created claims from the ground up. And not on here are a number of consultants, and we have a number of consultants that are a variety of types, and I'll go into them in a second. But just to say that the telephone names and phone numbers of all these people are on our webpage. So why is there a requirement for specialty mental health? First of all, we're not covered by, Knox-Keene is a law which covers the managed care plans that are not specialty mental health, so that would be Blue Shield, it would be Cal Optima, it would be LA Care, and they have regulations, and I believe it's a Title 28, so it's California Code of Regulations, Title 28, that set a number of standards for them, everything from consumer satisfaction, so there's some overlap, to timeliness of service, and that's something I think that a lot of people are interested in. And these plans are not, the specialty mental health is not covered by Knox-Keene legislation. So the requirement exists because the state has a Medi-Cal plan with the federal government. Part of the federal government that has the plan with is CiMH, Center for Medicaid and Medicare Studies Services. And the Medi-Cal plan has a waiver from federal government which addresses many things, including the rehabilitation option. It also has within it the freedom of choice waiver, and here's why we're here. That's why I'm here. As you know, if you have, in California, have Medi-Cal and need specialty mental health services, you need to get them through the county. And the feds ruled that that sounds an awful lot like managed care, because you can't go to any willing provider. Now, the truth is, in 1995, when this was rolling out, that's when they did inpatient consolidation first, there weren't any willing providers. And the mental health directors at the time said, well, they aren't willing providers because people don't want to go to offices, people aren't willing to accept the rates, and so the mental health directors worked with the then State Department of Mental Health to develop a specialty mental health plan waiver. And for a number of years, states fought the requirement, states that did this fought the requirement that there be an external quality review organization, but we're here to help protect the consumers because they don't have a freedom of choice. They can't go to, even though we know there weren't any willing providers, they couldn't go to them if they wanted to. And so just like if you have Kaiser, if you have Blue Shield, there is an external quality review organization that does a lot of client protections for you. They do consumer satisfaction surveys. They look at outcomes of services, and there's a number of very technically prescribed activities. So once again, the common name for our organization is CAEQRO. If I ever were to brand this again, I'd say I would make our webpage APS CAEQRO, because CAEQRO is very generic and we don't get any credit for being us. Here's what we're charged to do. And we're charged to review the mental health plan. So I don't want to jump into the issue that is raised by Berkeley. Berkeley is not a mental health plan in the same sense as Alameda County is a mental health plan, and that's because Berkeley doesn't have a separate contract with the state to be the mental health plan. Alameda does, and that's just a civics lesson. That's just the way it is. But the review domains are defined by Center for Medicaid and Medi-Cal. It's access to service, timeliness of service, quality of service, and outcomes. And actually, outcomes aren't really mandated under the federal regulations. They're an optional activity. But when we started with the Department of Mental Health, they asked us to start including outcomes. Some things that aren't in our purview. We don't do fiscal audits, which means we also, as a result of our review, currently there are no financial sanctions. So a county that does very well and does not lose any money, nor does a county that is not doing very well in our reviews. We don't do chart reviews. So a lot of you may be aware that in your counties, every 3 years there's a triannual audit, and people go in and make sure the T's are crossed and the I's are dotted. We don't do that. We don't do analysis of non-Medi-Cal claims data, and some of those other data sources that are really important, but we don't have access to it. It's CSI. There's it's a separate database that's maintained by the Department of Healthcare Services now. DCR, I forget what it stands for. That's the database which manages the outcomes for full service partnerships. And we don't have IMD. IMDs are residential facilities greater than 16 beds, and you cannot collect, unless you're over 65 or under 18, people who are in those kinds of facilities, you can't bill Medi-Cal for them. We don't directly look at MHSA programs. However, we do look at a lot of MHSA dollars because many, many counties, if not all of them, use some MHSA money to match the federal money in order to pull down Medi-Cal. That was not, I think, the original intention, but that's the reality as other dollars started drying up at the same time that MHSA was coming on board. So when we first started, the mental health directors didn't want to talk to us about anything MHSA, which was too bad because that's where everything cool was happening. But now they do. Now because everybody's has just owned up to the fact that there's MHSA dollars in Medi-Cal services. Yes, sir.
Could you go back one slide?
I hope so.
Thank you.
Okay.
No, everybody should have a copy of the slide set on their table, so you shouldn't have to worry about what.
Thank you. Yeah.
Hey,
Excuse me.
good point. Good. No, that's okay. Good point. The other thing that's interesting is. Yes. Question.
Small request. Would you please lift your microphone?
Sure. Yeah, I'm sorry. I'm a known mumbler, and okay. But thank you. Was there another question before?
What percentage of those that you don't do represent the part of the population that's also receiving services?
Are you asking what percentage of the people who are seen by county mental health programs is Medi-Cal, or which one is not?
You say analysis of non-Medi-Cal claim data such as
right.
CSI.
Right.
Those particular categories, what percentage of the population?
Oh, theoretically, 100% of the people are in CSI. And the problem is CSI, the counties have, until very recently, the last couple of years, county have been quite remiss in reporting CSI data, which is this whole separate database which includes more than just the funding source. It has a lot of interesting data fields in it that we'd like to query to take a look at things like outcomes. But counties have been remiss in collecting it, even though it's a federal requirement. And now that many counties have caught up, they've put it in, but DHCS hasn't sent it back to people to see how good it is. We don't know how valid the data is that's in CSI. because a whole ton of it just got added in the last couple of years.
Now, help me walk through my question that your data primarily looks at Medi-Cal.
Yes.
Okay. So what percentage of the population in the state of California receives services that's not funded by Medi-Cal?
I don't have that information. I can tell you that in a typical year, about 450,000 beneficiaries receive at least one specialty mental health service.
So then let me phrase the question another way. The data that you're reporting on would represent what percentage of the population in the state of California that receives mental health services?
I can't tell you because I don't know what what services are provided that are not billable to Medi-Cal.
So this is just a snapshot of Medi-Cal.
Yeah, because we are helping the state meet a federal requirement for the Medicaid program, which in California is Medi-Cal.
So then that leads me to another question, and not to take the time. So the information that we're getting from your particular organization only gives us a brief picture, a small picture, or Medi-Cal picture of those who receive services. That's
correct.
Okay.
And everything, when you look at our data, that's the way it's labeled.
Okay.
Everything's asterisked and labeled. It is a vast majority of the people who are receiving services. There are many counties who have hardly any money to treat people other than Medi-Cal beneficiaries. So it varies from county to county in a major way. Yes?
Okay, does that mean all facilities, okay, like Golden Valley, they do...
That's the FQHC in your...
Pardon?
Are you speaking about the Golden Valley FQH, the Federal Qualified Health Center? We don't have their data.
Okay, but you guys do check on them or do an evaluation on that?
We are not, no, because that's not specialty mental health.
Oh, okay.
Have I been there? Yeah, and I've been there in part of the review. I think you're from Merced County. We've talked to them to see how they're doing with Merced County. I did that a number of years ago. And so they're like stakeholders that we would interview as part of a focus group. And now they also have some, at least they used to have some contracts with Merced County for specialty mental health now. And I think they got some MHSA money. I just don't know the details, but they're at FQHC that's in a couple of counties. It's a really good, seems really good.
They got a federal loan too, I think, a federal.
Okay, I'm concerned about not getting through the agenda, so I'm willing to answer questions. You want me to, how about if I just go a little bit further and then, okay? Okay.
You keep saying specialty mental health. Is there a difference between specialty mental health and regular mental health services?
Yeah.
Yeah, well, okay, that's a whole separate subject, and it has to do with the fact that more and more individuals who have Medi-Cal are being put into Medi-Cal managed care, if not all of them. And in those individuals who need services, say their symptoms are mild to moderate, are supposed to be served within the mental health, within the health plan. Specialty mental health is for people also with moderate to severe.
Oh, so 2 and 3.
Well, there's an overlap. It's going to be fun to see how it plays out. There's both groups have some responsibility for the moderately ill individuals. And the counties are supposed to be developing, county specialty mental health, county mental health plans all have to develop memorandums of understanding with the managed care plans in their counties. And that will govern some of the issues about how many people are seen in the medical side versus how many are seen in the specialty mental health side. This is a whole separate subject. Let me go through this thing. Okay, I'm sorry, but it's, so what came up here is currently consumer satisfaction surveys are not in our contract. In most states, they put consumer satisfaction surveys as a responsibility of the External Quality Review Organization. But as you heard, Cricket's going to be in charge of that, and we're going to be talking soon because our contract's up for bid, and whoever gets it is going to have a responsibility of looking at CiMH's consumer satisfaction surveys and writing to them. The word in the proposal is used validate, is validating. I don't know if they knew what they meant when they said that, but we will be writing to them if we get the contract. Okay. I want to talk a little bit about how we prepare for a review. We use claims and eligibility data to create management style reports. So the data that is in your notebook that was borrowed from us was produced from Medi-Cal claims and eligibility information. And we have that data because one of our tasks is to take a look at how the integrity of the claiming process in the counties. However, when we started in 2004, we had this data, and when you start up a project, things are slow until you figure out that you're behind. And we had this data, and one of the analysts and I sat down and said, boy, if we'd had this data when we were working in the counties, what kind of report would we make? And it was from that discussion that a number of the reports that are on our webpage came from. We also thought that we would not be continuing to do data in 10 years later, because really in the medical side, the plans produce the data, they send it to the External Quality Review Organization, and the External Quality Review Organization uses specific procedures to validate the data, whether it be consumer satisfaction, time to first visit, a number of quality indicators as were talked about earlier today. In California, the state of affairs is such that not many counties could produce that data. So we're continuing to produce that data. And it's not the world's greatest, but one of the reasons claims data is useful is there's a real clear incentive for that data to be submitted. I was pointing out the CSI data, that didn't get submitted for years and years because there were no penalties. People got paid regardless. You don't get paid if you don't submit a claim. So, and there's not much of an incentive to sit on the claim. People tend to get it in quickly. So claims data, which represents, I think there's $1.2 billion in Medi-Cal claims per year in California. About 70% are done by community-based organizations, and about a third of the Medi-Cal is done in Los Angeles, which in our data is listed as a very large county, if it's not listed as Los Angeles. So we do cover a whole lot of, we do feel our data is useful to display an important slice of the picture. And in fact, the counties and the consumers we've run into feel empowered to have this data. What we've tried to do is say, set it up as a model. But as was raised, and we hope that each county would then adopt some of what we've done. And in truth be known, they have over the years. It's been gratifying. So we prepare for a review. We take a look at claims and management reports. We assemble a review team. Our review team always includes a consumer family member, a lead reviewer who's a clinical type person usually, and a technology reviewer. Before we go out on a review, we review submitted materials. And we have, the way we handle it, we have pre-site calls and post-site calls to talk about everything from logistics to what are we going to look at in the county to what are the meals going to be. And consumer family members participate in all of those kinds of calls. And I just want to mention, this is, it's not clear enough for you to read in your handouts, but if you go to our webpage, or if you've read if you've read your county's mental health plan report, which is on our webpage, then you'll see that there is a table of many pages of data that kind of look like this, and that we have generated that. That was what's become of my dream report from 2004. And what happens on site reviews? We gather information to supplement submitted materials, and I wanted to show you a sample agenda just to give you an idea. And this actually, I realize, happens to be the agenda for our recent Orange County review that I was on. And this was we are on a review from anywhere between 1 day to, for LA, it's 4 days, and we have a double team. But this year, for a number of reasons, for Orange County, we had 1 day. But we actually started the day before because it was convenient. One of the things we do as a consumer family, we do focus groups, and they felt they could get more people to attend a focus group at night. And so we did it actually the night before the review. Then things that happen, we have on the day of the review, we have a large session that usually the mental health directors involved with. Mary was actually at a meeting, and so Dave Horner ran the meeting, and he's their quality management director, among other things. So we would look at how my light went out. Okay. We take a look at performance improvement measurements, utilized access, timeliness, outcomes, and quality. We take a look at examples of reports that they use to manage performance. And we then take a look at the Eqro approved claims data. And that's somebody earlier today, somebody had that extract from one of our reports that had pie charts and things that reflected some of the data. So that's a morning session. Then we have a session separately on outcomes, timeliness, and disparities. So one of the things we've been able to do is stratify our data by ethnicity, or actually by race, actually. And it's the race that's identified in the state Medi-Cal eligibility files, which isn't perfect, but it's consistent. So we'd have we'd have a session on outcomes, timeliness, and disparities. And then I happened to be involved. We were talking to a number of executive directors from community-based organizations to see how they felt they were integrated into the system. And the system could mean, are they using the same electronic health record? Do they get good information? Do they get training from the mental health plan? Are there business practices involved which impair the ability for the community-based organizations to carry out their mission? We have sessions on, there's a specific kind of a project that has to go on called the Performance Improvement Project. Anybody in the room know what their county's performance improvement project is? Each county has to have 2 running all the time. Anybody know? You sort of do? You should know this. They should be, that's one of the things we ask. It's an important thing, and the quality assurance committees that hopefully have, or improvement committees that you hopefully have, a number of you hopefully are on, should be talking about the performance improvement projects, which are projects designed to improve processes, to improve outcomes of care. It does involve math, and that's what's a really hard time. It gives people a hard time.
We have a quality review council.
You might have, yeah, but some places call it a QI committee, some call it a quality review council. There's just a gazillion different names for it. So we also did we met with the manager for information systems and talked about the billing issues. As I said, we have a need to do that. This is a part of the review that I think is extraordinarily important. We've made it a priority throughout the state to have hire people with lived experience. How that's been actually done is different throughout the state. So we check in with those folks. We ask wild and crazy things like, do you have a job description? Do what you do, is what you do anything like what your job description is? Do you ever get evaluated? Do you get accommodations? How's it going? So we ask those kinds. Do you get benefits? Are you a county employee, or are you an employee of a contract agency? We also do some special sessions on healthcare integration. In Orange County, they were beginning to implement electronic health record, so we had a special session on that. We had a focus group at the Wellness Center. And what's interesting, I think is interesting, is we don't have the same groups in each county. We customize our review to follow up on findings from the previous year or things we've heard. Or sometimes counties actually ask us, we'd like to know how Group X is doing. Could you make sure to do a focus group? So give you an idea, in the fiscal year 12-13, so that was last year, we conducted 56 reviews. There were about 2,500 staff and stakeholder participants. We interviewed over 300 individuals representing 296 different agencies, and we conducted 87 consumer family member focus groups that had a total of approximately 700 people. So I think we're in a position where it's not a random scientific sample, but we do get lots of information. This is data from people who are using the services. So what are some data? So this is some really, it's amazing that I have no pie charts. I'm just showing you some data. And the reason I'm going to show you this is because it's not hard to see. This is very high level data, and I want you to tell me if you think it's good news or bad news. So in 2006, there were 426,000 individuals served in specialty mental health. In 2012, 469,000. Not bad, huh? That's good news, right? Not good enough for you? Okay. Foster care, we do then and now. Well, what's going on here? The number served is going down. Because, you know why? Because there's been an initiative in the social services throughout the state to not place people into foster care, and certainly not to place them out of the county whenever possible. So the number of people in foster care is actually going down. But that's not a bad thing. That's part of the plan. So I raise that for an issue, is you just can't say, just look at the number out of context. You have to look at it in the context of the whole system. Look at this. Hispanics or Latinos. In 2006, 116,000 served. 2012, 164,000. That's a pretty big improvement. I don't understand why people are not touting that, actually. And then we have other subgroups that I'm not going to show.
The penetration rate is not presented in the context of what we would anticipate it to be if we got everyone who needed help. So the context, we're missing the context.
You're missing, yeah, right. And the penetration rate, you have to take a look at, the penetration rate is made by a numerator and a denominator. So here's a story. We were at a mental health plan that really had a low Latino penetration rate. And on our data that this year we submitted, it looked to them, wow, our penetration rate went up. But it was really in one of those examples of the operation was a success, but the patient died. Because while their penetration rate went up, the number of people they served went down. And in fact, what existed is the number of whites they served went up, and the number of beneficiaries that were white went up. So they had a problem in their local Department of Social Service office. Whoever was signing people up for Medi-Cal was not filling out the ethnicity correctly. But they thought they had done a lot better, but they weren't doing better, because you can't do better if you're serving less people. But that's just one example. You've got to take things in context. Well, okay, wait. Well, whoops. So we know a little bit about data. Let me just get to the end. I'm close to my end thing. And so I'm going to be referring you to the pamphlet I handed out. So if we know a little bit about data, can we critically evaluate stuff that's in our environment? So this is the pamphlet. It was actually handed to me by the relatively newly appointed executive director of the Mental Health Directors Association, Robert Oakes. And so this is called Meeting the Needs of Californians. And it's got some nice charts and tables. So let's look on the back, though. So let's say, sometimes you just look at the back of a pamphlet. And access to, I don't have a slide for this, access to service, saying number of days to first appointment is 14. Well, that would be really good if that went on throughout the state. And I can tell you that I was puzzled by that, because I know what people report to us on that issue. So then I started looking at the pamphlet. And look at the front page. right at the top under Recovery Works, this actually turns out applies only to the 27,000 individuals who have been served through full service partnerships in 2005. So this applied to 27,000 out of the approximately 450,000 people who were served. So it's a good thing, but you got to take it into context. This is what some people would call line with statistics. Some people would call, I call it strategic truth. It should have been labeled better. It really should be, and we endeavor to keep a higher standard than that. Including, like, it doesn't really tell you where this data came from. It must have come from that DCR database that I referred to.
Appointment or evaluation?
Well, that's a whole other, that's another good question. The question is, do they mean appointment or the first visit? I know that those are questions that I think I would really like you folks to be asking of your mental health plans.
Just an appointment or first visit.
Well, what do you mean by that? You know, and then what do you think it should be? In many counties, it means to the first appointment. In some counties, they can't even measure it. Okay, there was a question down here.
I got two questions. During your review, toward the end of the review, you have a meeting with the staff and the county people, but nobody is allowed in that meeting. Why? I mean,
well, we don't have an exit review. The question is, why is nobody allowed? First of all, anybody, from our perspective, anybody can come into any of these meetings except for the specific focus group. Sometimes when I'm talking to line staff, supervisors show up and I ask them to leave. That's a nice way of saying it. I throw them out. But we, in many counties, the director will invite the mental health board to particularly the first session. In other counties, I have not seen a mental health board member there. We don't do a formal exit because we haven't had a chance for all the team members to come together and give their input. And we've learned that if we say, hey, it looks pretty good, people think everything looks pretty good. And so our closing thing is now we just ask questions of information that we didn't hear that we need to hear.
So at the last meeting, just be asking.
It takes a half hour, maybe.
The county personnel questions.
We just ask them questions. Like I was at a county recently, and there were some of the caregivers of kids seemed to be saying that they could no longer get mental health staff to go to an IEP. So, and I heard that from staff, and I heard it from a parent. And I didn't know what the county's policy was, so the question was, what is your policy on your staff being at IEPs in schools? So.
Some of you guys are pretty sharp in there, because you guys, for some reason, these surveys are a big thing where I'm at, but you don't look at surveys, supposedly.
I don't look at the consumer satisfaction surveys. On the other hand, people do show us, sometimes people are doing performance improvement projects related to consumer satisfaction. There's a number of counties that have exceeded what the minimum requirement is for consumer satisfaction, and they use a variety of instruments. Actually, in the managed care world, consumer satisfaction is often paired with information about timeliness to service. So when I see how Blue Shield reports its timeliness to the Department of Managed Healthcare, they're saying, okay, we're making our first visit by this time, and here's some consumer satisfaction surveys results that support that people are happy that they're getting what they need to get. To me, so that's not just data, it's not just one kind of data, it's two kinds of data to substantiate how they're doing.
Yeah, because I was going to say about 1 year, they had all these satisfaction reports, and what happened was you guys said, well, this can't be realistic because there's nobody complaining about the product. So you can't have that. You can't be too perfect. How can you be perfect? In other words, they wrote it up and they go, well, this does not compute, because everybody, when they did the survey, satisfaction surveys, they were all hundreds.
And yet, and when we talked to people, there were a number of individuals who had some issues, probably.
Right.
Yeah.
Yeah. Then they were like,
That's it. So what I mean, I've gone over. So I just want to before I totally get thrown off. Here's what the front of our web page looks like. Here's where our reports this is a tab where you could find each county's report, and it's usually posted within 90 days of the site visit. And then this tab here is where there's data analysis. So in there include things like spreadsheets that you can filter. So you can filter some things by penetration rates and compare you can do it by small counties, large counties, those kinds of things. And as far as I know, this is the only place where these kinds of spreadsheets exist. Yes, there's a question.
A couple of things. First of all, whoever role it is, it would be good to have standardized distribution of the surveys. It would be good to have standardized distribution of the surveys, as well as standardized recruitment for EQR focus groups. As well as standardized recruitment of EQRO focus groups. It would be good to have both so that there isn't that sort of disparity as in one county doing peer specialists, and in the other county, the case managers might be handed out, and so it can be presumed that some clients may be very reluctant to write anything negative. And I just want to, because I want to have enough time to cover this, as far as the EQR focus groups, it's important to have objective recruitment also. For example, when we made the request, our commission passed a motion to request an EQRO, which nobody except for me even knew the concept existed before that. We also asked that a letter go out to every client, a notice of the opportunity to engage. And instead, as I learned from your report, only 3 people attended and they were hand-selected, which is exactly what we were trying to avoid, so that there could be objectivity and that people would be picked in order that they responded to be in the focus group, so that there was no bias. So let me ask you, is your issue with us or with your mental health plan people? Well, actually, I just think it would be good to have something standardized through the state, throughout the state. I agree, but we don't have consensus on that. And also, I think what you have to weigh is some counties, you know, certain things are covered pretty well. In other counties, and you want to follow up different issues. And we're only doing a really small review. We're doing a lot more than other EQROs do. We haven't been funded to do the kind of thing that you're talking about. I'd like to do consumer satisfaction to people's addresses. That's a real problem, though, because they tried that a number of years ago, and the mental health offices or the offices of the conservators received all those letters. I know we did in San Francisco. We sent out thousands of letters, and they came back to the person who sent them out, because it turns out many people have listed the conservator's office, which happened to be at our address, as their address. So it's not easy to do that, you know. Can consider in terms of standardization. The other thing I wanted to mention quickly is, unless it was otherwise listed, when people were satisfied, was there a distinction between ethnic groups and monolingual or bilingual persons, and also age other than child and adult? For example, you've got the big transitional age youth group that's not a child, a young adult, you've got older adults. And so I would like to know the dissatisfaction or satisfaction within the various groups and the ethnic populations, and also if there's a way to compare the needs of a community with the clients, because clients may not, the mental health department may be, perhaps through no fault of their own, may not be meeting all the needs of the community, in the sense that maybe some cultural groups are less likely to seek help, for example.
So thank you, Carol, very much for those comments. I mean, you've hit the nail on the head in many areas, and there are things that I know that a lot of people throughout the state are actually looking at. I agree with you. But, and
Michael, I realize that you know, there's a time crunch here, but would you be available after after this for questions?
I have a 5:30 plane, okay, so I got plenty of time. And I just want to say that here's my phone number, and all of our phone numbers are on our. If you go to the web page and about the EQRO, all the phone numbers are there. And we're available to the extent we can be to come out and actually do technical assistance and training. I would love you.
I want to reiterate what he's saying. Did you hear what he said? He's available to come out and do technical assistance and training. And one of the offers that he has made us recently is that as you go to complete your notebook, if you have questions about your EQRO data, you can contact the person that was the lead reviewer on your team, and they will help you walk through that data or clarify the questions that you have. What a great offer. Thank you, Mike, so much for that offer.
And I even told the staff to expect calls. Usually they say, wait, how come somebody's calling me? But actually, we get calls like that all the time, and we love them. You know, we'd love you folks to have a stronger voice in our reviews. I'd love to know that there's always a mental health board person, at least in the first session, and I'd love to have you help us get attendance at focus groups. You know, one of the things that happens is some people in the county say, well, one person complains and we generalize. No, we don't do that. You know, we may hear it. One person in one group may say it, but then we hear it in 2 or 3 other groups that we do. Then we say, this sounds like this is an issue. And the counties surprise, surprise, the counties that hear the consumer voice are the ones who want to hear more about what we have to say than some of the other counties. So I'm really pleased with the fact that we've done these consumer groups, and we've also done them in about, I think, all the threshold languages and American Sign. We might have missed one of the threshold languages, but I think we've hit all 12 in Los Angeles now. And I thought we had done them all, but then somebody at one of these planning council meetings said, have you ever done American Sign? And I went home, so I did. We've done 2 now. So.
Thank you, Mike.